In our opinion, it is more, it has always been more than amyloid-β. If we go back to Alois Alzheimer did not focus a lot on amyloid plaques. He instead focused on the neurofibrillary tangles, and not just a few neurofibrillary tangles, but a lot of them in the neocortex. So Alzheimer was somehow a Taoist. He focused on neurofibrillary tangles as well as the clinical picture of his patients. So we are definitely into a clinical pathological condition since the very early ages of Alzheimer's disease. Of course, the genetic findings in the 1990s, as well as the amyloid cascade hypothesis, has deeply influenced our current knowledge. However, it works well in autosomal dominant Alzheimer's disease, but in sporadic Alzheimer's disease, amyloid certainly plays a role, but is not the only cause of Alzheimer's disease. And additional factors, and we illustrate that with the recent finding of GWAS studies that have highlighted more than 70 loci on different biological pathway, much beyond amyloid pathways such as microglia, lysosomal, or tau pathway, but are very important in sporadic Alzheimer's disease. So we are in a different model in a sporadic Alzheimer's disease. It's not as simple as the amyloid cascade. So we need to think beyond amyloid-β. We need to think beyond defining Alzheimer's disease only on an amyloid PET scan, because it reduces the biological complexity of Alzheimer's disease. That's the first answer. That's the basic neuroscience reply. And then you also have a public health reply, because when you define Alzheimer's disease only based on an amyloid PET scan, then you multiply by 3 the number of individuals who can be labeled with Alzheimer's disease. And when you multiply by 3, you include a new majority of individuals who don't have symptoms, of course, but within those who don't have symptoms, the majority will not develop symptoms either. So we risk diluting the gravity of Alzheimer's disease. And when we dilute this gravity, we, of course, risk misunderstandings, like the assumption of a poor prognosis in an individual who is labeled with Alzheimer's disease in a biological concept of Alzheimer's disease. So there's a high risk in this biological transition. Of course, transitioning to biology is necessary for treatment. That's why we propose the pre-symptomatic Alzheimer concept, which is asymptomatic individuals with biomarkers, but we ensure that these biomarkers are confer a high risk of developing Alzheimer in the future, meaning that we move to preclinical Alzheimer, we move to biology, but we stay aligned with the historical concept of Alzheimer's disease. We avoid misunderstandings. I think it's a much better concept than transitioning to a pure biological concept. Well, I think that's very important that we have this debate in the field. Congresses are excellent places for debates. We should have more of these in the future. And I know it's not always easy, since the Alzheimer Association also organizes the main international congress on Alzheimer's disease. So it's sometimes difficult to have a debate on this criteria in the congress. But I think it's necessary for the field, because we need to reach a consensus. Now, having 2 definitions of Alzheimer's will be detrimental to researchers. Now, everybody will discuss what Alzheimer's disease are you talking about. At the beginning of each talk, it will create confusion. So we need discussion, we need consensus, and we need to move forward towards biology, but with a clinical picture in mind, to remain aligned with both the patient and the scientist concept of Alzheimer's disease.